Good morning, and welcome to today's webinar called TIA or Stroke, Does Etiology Matter? My name is Sue Verrilli, and I'm the Regional Education Coordinator at the Northeastern Ontario Stroke Network. We're happy that you could join us today. If you're watching this webcast with others, we ask that you follow the PPE guidelines set out by your workplace and public health while viewing this webcast today. As well, please type in the names of those watching with you in the question and answer box for attendance purposes. The presentation handouts were included in the meeting request that was sent to you yesterday. Please email me if you did not receive them. This webinar has been CME accredited, and a certificate of attendance will be sent out to each registrant next week. If you're watching this webinar as a group, please type in your name and email address in the chat so I can send you the certificate as well. You do not have access to your camera or your microphone for this webinar. Please use the Ask the Question box to ask your questions, and I will relay them to Dr. Singh at the end of the session. If you are having technical difficulties, please click on the Technical Support button on the top right corner of your screen. Try refreshing your screen first to see if that resolves your issues. In the case scenario portion of this presentation, we will be asking questions using the poll function. Please click on your response when the poll appears on the screen. I apologize in advance if my polls don't show up precisely at the right moment when Dr. Singh is speaking to them, as there's a 20-second delay between our speaker on Zoom and the Webcast Canada platform where you are viewing this webinar. On the main page of the webcast, you can find a link to the evaluation survey. Please take the time to fill it out today. Your responses will help us improve our presentation and give us ideas for future stroke education. In order to mitigate bias, the speaker has been provided with a speaker letter outlining the certification accreditation requirements for the presentation, and we've reviewed the presentation prior to delivery. If a breach is detected, we will approach the speaker to discuss the concern and update the presentation as required. On behalf of the Scientific Planning Committee, I would like to disclose that we have received financial support for this symposium. This program has received an unrestricted educational grant from BMS Pfizer Alliance, as well as financial and in-kind support from the Northeastern Ontario Stroke Network. At this time, I'm pleased to introduce you to our speaker, Dr. Ravinder-Jeet Singh. Dr. Singh is currently an assistant professor at the Northern Ontario School of Medicine, and he is a stroke neurologist at Health Sciences North in Sudbury. He completed his medical school from JJM Medical College in India and neurology training from the National Institute of Mental Health and Neurosciences, NIMHANS, also in India. He did a one-year stroke fellowship at NIMHANS before moving to Calgary. He completed his two-year vascular neurology fellowship at the University of Calgary. He has a strong interest in studying the role of brain eloquence in stroke prognosis. He is also passionate about studying long-term outcomes after stroke, cerebral collateral imaging, and symptom imaging correlation in cerebral venous sinus thrombosis. Welcome, Dr. Singh.
Hello, everyone, and thank you for joining this webinar today, and thank you, Sue, for the kind introduction. And so today, this is an important topic which we'll be discussing, which is TI and stroke, and how does etiology matter in the TI stroke. And there will be a few themes I'll be discussing and sharing, and also there will be a personal touch to the individual approach, which I use towards the end to make things simpler. So regarding disclosures, I do not have any relevant disclosure related to this presentation or content of the presentation. I would not be making any specific recommendation regarding any particular medication or any procedure. Being part of the stroke program at Calgary, I was part of the several trials, and the rest of the disclosures are mentioned here. So the objective of today's webinar is to discuss different stroke etiologies as they relate to TI and stroke, and to explain the clinical approach to determine the etiology, which basically is to familiarize everyone what the different TIO stroke etiologies are, and how do we really classify them so that we can understand the basic groups, and which then could be used to make decisions to individualize treatment. And finally, to discuss some of the common stroke etiologies and the specific management with some of the recent evidence as available. So if we look at the stroke and TIA, oftentimes we think this is the diagnosis. But I'll try to convince you during the next few minutes that the TIA stroke is not the diagnosis in itself. It is similar to saying that somebody with dizziness has vertigo, and vertigo is just a symptom presentation. It's not diagnosis by itself, because it could be caused by vestibular neuritis, could be caused by benign paroxysmal positional vertigo, or it could be caused by serious condition like stroke. So similarly, each TI and stroke carries its own etiology, and it's the etiology which determines how the stroke will subsequently behave. So to start off, we all know that there are two major themes when we discuss about stroke. There's an ischemic theme and there's an hemorrhagic theme. Now, in the past, we have used the term attack, especially in the TIA or the accident in terms of the stroke, but it was called a cerebrovascular accident. Now, whether you want to call it as a attack or an accident, it is really a matter of personal preference. But the concept or the theme here is that the ischemia is the primary driver here. It's the primary or the key mechanism here. And we won't be discussing about the hemorrhagic stroke, because that's in itself is a separate topic. So we'll discuss things in three basic parts. The first part would be why it is essential to understand the stroke or TI etiology. The second part, I will be discussing and introducing the concept of the classification or etiological classification. What are the different groups or the categories of the stroke or TI etiology? And the last part would be how that grouping helps us to basically determine what sort of treatment we should offer. So I'll try to keep it very simple. So the first question is, why should I bother about the etiology? And to get into a little bit of philosophical mode here, I think if we look at some of the important progresses which has been made over the years, the philosophy has played a key role in that advancement. And one of the important concepts in philosophy is causation and or causality. And if you look at Aristotle's view, is we think we have knowledge of a thing only when we have grasped its cause. So the cause or the causality or the causation is the key concept here. And in the physics, we think we do not have knowledge of a thing until we have grasped its why. That is to say, what is its cause? And again, this is kind of my interpretation of causation or etiology. Is it's an illusion, not the reality itself. And it explains the pattern of events, and our mind introduces then the sequences in that pattern to understand its direction, and that helps us understand what the etiology is, where we understand one is leading to another, and the former is considered a prerequisite or the cause to another or the effect. So now coming out of the philosophy, we understand that TIA and the stroke is a diagnosis, but if you look at this part, it'll make it very clear and obvious as to why I'm saying it's an outcome with its own etiologies, and not why this should be our ultimate because diagnosing a TI or stroke is not that challenging. The more challenging part is understanding its mechanism or the etiology. So what we are seeing is the TI or stroke is the final outcome. It's the final expression of something which is underlying, which we call as a mechanism. And as we understand today, the ischemic stroke has only three basic mechanisms. Either there is a thrombosis, there's an embolism, or there's a hyperperfusion. And even to make things simpler, hyperperfusion actually is a common theme to all three. The idea of using hypoperfusion is if there's no local changes in the brain arteries, but you're still seeing the stroke, we think there could be a distant mechanism, and that's a concept of hyperperfusion, and we will talk a little bit more about it. So now looking at the mechanism, which is the immediately preceding the outcome, we have something which leads to this thrombosis, or which leads to the embolism, or which leads to the hyperperfusion, and that's what this etiology is. And I will explain in the classification section that we basically have 5 major categories of the etiologies. And we will be discussing all 5 today. May not be fifth may not be the core, but at least the first 4 we will discuss because they are the common ones which we see every day. And at last, all etiologies mechanism are finally related to the underlying risk factors. And if you want to understand the etiology, it's like a final cause, while the risk factors are preceding causes, which leads to the final cause. And so in a way, all that is interlinked. So that's why in the stroke literature and even in the medical literature in general, there's a lot of confusion as to what is really a risk factor, what is the etiology, and what is the mechanism, and then where does the stroke as a diagnosis stands. And if we understand this sequence, it's quite obvious that everything starts at genetic or environmental factor leading on to the final cause or the etiology, which leads to some mechanisms producing outcome, which is TI or stroke. So this is this is the common theme, not only in stroke, but every condition affecting the human or even living being. And what we are going to discuss is about the etiology and what are different categories, because this is the most proximate event to the outcome, which is TI and stroke. And this is what determines the behavior of the TI or stroke after it happens. And if you look at the TIA registry, which was one of the largest TIA study done to date, where multiple centers from different countries, they participated in this study. And the idea was to understand what is the natural history of the TIA. And if you see, if somebody experiences transient neurological symptoms, which are ischemic in nature, which is TIA, the risk of subsequent stroke varies widely. And it ranges from as low as about 2% to as high as up to 8 to 10% in the next several months. And most of the risk is, as you can see, is front-loaded, where most of the stroke tends to happen after a TI in the first few weeks. And if you see, you can clearly see that there are 3 major categories. The one which is of highest risk is the one where you have a large artery atherosclerosis, where you have either a large artery disease affecting the extracranial circulation or the intracranial circulation. While the TIAs of undetermined cause have one of the lowest risk of recurrence, and while all the other categories kind of fall in the middle. And therefore, it's very important that to determine the etiology, because that'll determine then the behavior of this TIA as to how this will cause subsequent strokes. And If we look the brain part, so this is about the vascular part or the cardiovascular part. If you look at the brain aspect, and if you look at the brain parenchyma, depending upon how many strokes you had, the risk of subsequent recurrence varies widely. And this could be considered to be a tissue equivalent of multiple TIA strokes. As we know that somebody who had a single TIA is at a lower risk compared to somebody who had multiple TIAs in the same territory. The same thing works for the brain as well. If you see a single stroke compared to another patient who had multiple stroke in one arterial distribution, the risk of subsequent stroke is much higher if somebody has a multiple stroke, again suggesting that there's probably either recurrent embolization or multiple embolization happening. So again, emphasizing why it is important to use a brain and vascular imaging to stratify the risk following a TIA or a minor stroke. And this was an extension of the same study where not only at 1 year, if we look at 5 years and compare what are the etiologies which are associated with the highest risk of recurrence, you can again clearly see that the large artery athero has much higher risk of recurrence compared to the one which is of undetermined etiologies, and most of the other fall in the middle. So, so irrespective of whether you're seeing these patients early or we are talking about the long-term outcome, essentially there's one single theme, which is the etiology determines subsequent risk of recurrence. So at the end of the first part, the key message here is that TIA in stroke is an outcome and not by a complete diagnosis itself. Therefore, once we say this is TIA or once we say this is a stroke, it's the immediate or the very next question should be what caused it. And it is a cause or the etiology which determines what is the risk of subsequent strokes and how we should be managing these patients, which of course we'll be talking later. And the second part is that there could be either one or there could be more than one causes, and it is not uncommon to see a patient with carotid artery disease having atrial fibrillation in addition. So again, it's important that if you have one etiology, it doesn't deter you from identifying another etiology. And at the same time, it is not to suggest that we should be subjecting every patient for every investigation, but rather every patient should have some basic workup to look at the common etiologies and specifically to look into the etiologies which are prognostically very relevant. And the third key message here is that it's the cause, not the TIA or stroke itself, which determines the natural history in long term. Although the short term, it might be the stroke severity, which determines the prognosis of that particular stroke. But in long term, it's the etiology of the cause, which determines the natural history of this stroke, in particular the stroke recurrence as well as the vascular events. And we do know that if we can prevent a second stroke, we can significantly reduce the morbidity and mortality, because compared to the first ever stroke, the second stroke or the recurrent stroke carries a much higher risk of disability and mortality. And the last part is prevention of future events heavily relies on underlying cause. Therefore, the cause should be determined in every TIA and stroke patient. So that's kind of a key, which is theme is that once we diagnose a patient with TIA or stroke, the very next question should be to find out the cause. The second part, which is much smaller part of the presentation, is to talk about what are the etiologies. And basically, I'll be introducing a different key concepts here. And again, I'm not making recommendation in terms of what the algorithm should look like. And of course, we can discuss the algorithm too. But it is basically to introduce the concept and what are the different categories, because many of the physicians may not be familiar with these etiological classification. And now, if we look at the etiology of the causes, there are over 200 different causes of ischemic stroke. And so it becomes really difficult to investigate an individual for these different causes. Therefore, to make things convenient, these has been grouped into five major categories. The initial attempt was actually much before the Harvard Stroke Registry, but Harvard Stroke Registry was the first one which formally introduced the classification system in 1978, and this was subsequently modified and adopted by the Stroke Data Bank. And in 1993, this was a TOAST classification or trial ORG number 10172 in acute stroke treatment, which is the expansion of TOAST. The TOAST classification is the most common classification which has been used for the stroke etiology. And subsequently, the TOAST became a framework to develop subsequent classification systems. And there were multiple subsequent modifications which were introduced and leading on to different names. So I would be explaining basically what the TOAST classification is. And if you see here, it's not that difficult. And if you see, there are basically 5 different categories. And in those 5 categories, either you can start with a large artery atherosclerosis, but to make things simpler, I usually start with the cardioembolism. So you are basically starting from the heart and going with the flow. And so you have cardioembolic stroke, then you have large artery atherosclerosis, both in the neck and in the brain. And then you have a small vessel occlusion, which is in the brain. And then you have stroke of other determined etiologies. And finally, you have stroke of undetermined etiology. Now, the stroke of undetermined etiology should not be labeled as cryptogenic stroke because there could be several reasons why the etiology is not determined. And so the first is there are more than one cause which has been identified. Therefore, you cannot really put that patient into one single category. Or second could be it's incomplete evaluation. Patient was seen and emerged and there are not all the tests completed. So you don't have the complete information to classify these patients. And the third is a true cryptogenic stroke where your initial workup has been negative. And only the third category is, or the category B is the one which is truly cryptogenic stroke. And again, these 5 groups, and again, it's very easy to remember because if you start with the heart, go into the neck and brain and small arteries in the brain, and these are the defined ones, then you have other determined etiology, and finally stroke of undetermined etiology. So those are basically 5 big categories under which we need to classify, and each category has its own treatment approaches, and even the diagnostic approaches are different. And the second is, how do you determine then whether this is a large artery disease or a cardioembolism or a small vessel? So we can use a combination of factors here, which includes the clinical features, imaging features, and other investigation. And again, to make things simple, you are using clinical features, brain imaging, and the vascular imaging, and combining with the cardiac investigations. And of course, you're using additional blood tests as and when needed. And so the idea here is that in the cardioembolism, the stroke is embolic in nature. So there is involvement of the either cortex, cerebral cortex, or the cerebellum. While in case of the small vessel, they have a lacunar syndrome. So large artery atherosclerosis and cardioembolism, both of them have embolic features, while the small vessel has a lacunar syndrome. So either you can say it is cortical versus subcortical, or it could be lacunar versus a non-lacunar. So whichever way we want to consider this, the idea here is, does this patient have cortical symptoms like aphasia or neglect, which will qualify these patients for cortical strokes, which becomes embolic, that has to be either large artery or cardioembolic. While if there were no cortical features, that becomes a lacunar syndrome. And of course, the same thing should get reflected in the imaging as such. And so the cortical involvement, cerebellar, or the brainstem, or the large subcortical involvement would qualify for embolic, while if it is a small subcortical, that qualifies as a lacunar. So these are like a clinical imaging syndrome, which are further supported by additional cardiac or the vascular imaging. And so the only other thing which you need to add here is add cardiac imaging or vascular imaging. So we are basically starting with a stroke or TIA with cortical versus no cortical features, and then cortical imaging versus no cortical imaging involvement, and cardiac investigation positive versus vascular investigation being positive. Now, this is the most simplistic, and of course, you can add brainstem and cerebellum into it. And even if it is subcortical stroke, which classify as lacunar, but if the lacune is very large, then you should suspect there could be embolic mechanism. And so once we know that these patient is in one of those three big category versus some other cause, the next question is, even these cardioembolic or large artery athero itself has subsets. So we are now going into more granular information here, which is once we say, well, it looks to us as a cardioembolic, but then we have to look for what are the potential sources. And again, I will try to simplify this long list, because when we initially look at it, either you can keep these lists handy, or you can use a simpler framework, which I'll be proposing. And again, this is another where a classification system where it was made more objective, because if you look here, there's a lot of subjectivity in this classification. And here you add objectivity and level of certainty to the evidence, and therefore calling it possible, probable, and evident, which is also the same concept is also used in many other conditions. And but the theme remains the same. And if you look at these categories here and categories here, they're essentially very, very similar. And these are the many other defined categories, conditions. And this list is incomplete. So again, suggesting that knowing the etiology is crucial, and sometimes it could be challenging to determine the etiology. And there were subsequent further modification, and I like ASCOD because it kind of helps us remember the 5 groups, and it is missing some of them, which is, as you can see here, atherosclerosis, small vessel disease, cardiac, other causes, and dissection. So it doesn't carry the undetermined cause. So if you're not able to put into ASCOD, and so there you can say this is likely cryptogenic. And after that, there was a Sparkle study which used a plaque area in the causative classification system. So although initially these lists and the classification system appears daunting, but if you could understand the very basic, which is there are 3 big categories, and there's other determined etiologies and undetermined etiologies, that makes 5 groups very simple, easy to manage. And this is another classification system, which is not truly a classification system, because it does just gives us the severity, but for the sake of discussion, I just wanted to bring it up and mention it. It might be useful to for the prognostic purposes, because it basically tells you about the extent of the infarction and presumed location of the infarction. And so in summary, the most stroke etiologies could be classified into one or more possible cause. And in about 20 to 40%, we may not be able to determine the cause. And there are 5 major groups, with each has distinctive features, and each could be identified by its clinical imaging and with the help of other investigations. And use of a standard diagnostic criteria improves etiological classification. So that's the last part is to discuss the specific treatment options. And again, I will not be going into details of all the etiologies. I'll be giving you an overview as to what the core themes are. So what is most important here is the cardioembolism, large artery atherosclerosis, small vessel occlusion, because this constitutes about 20%, this constitutes about 20-30% extracranially, and 20-30% intracranially, and about 15-20% here. it depends on, the classification system used and how you are classifying it. So the numbers might shrink a bit, and number of undetermined etiology might increase. But over time, we are realizing that if you try enough, in most cases, you can basically establish the etiology. And I would say here at HSN, probably it's in about 10 to 20%, we are not able to establish the etiology. 80% of the time, there is an etiology which we can basically determine. And now coming back to the cardioembolic stroke, now if you look at the big list here and break it down into two groups, that makes things much easier. And what we are trying to look for is there any thrombogenic substrate, and is there any intracardiac mass? And because if there's an intracardiac mass, it needs a slightly different approach, and it makes things very obvious that the heart is the cause of the stroke. Now, if we don't have intracardiac mass, which is especially the thrombus, there could be an underlying substrate which puts the patient at higher risk of stroke. And the most important, which is there any atrial fibrillation? And two, is there any structural cause which is predisposing for thrombus formation? And heart failure by itself, it does not change the management, although there's a lot of emerging literature which are discussing about different strategies, whether we should anticoagulate these patients with low ejection fraction or not. So the general principles are that all TI and stroke patient with the high-risk cardioembolic source should be anticoagulated unless there's a contraindication. And the timing and the choice of medication will depend on the cardiac, stroke, and patient-related factors. In general, the metallic heart valves and significant mitral valve disease is the only indication for definitive warfarin treatment. Intracardiac thrombus, although the standard recommendation are we should use warfarin, but more recently there is an increasing evidence and inclination to use DOACs to treat intracardiac thrombus as well. And generally, it is continued for about 3 months, any form of systemic anticoagulation. And the longer anticoagulation will determine what caused the intracardiac thrombus. All structure indications except infective endocarditis, DOACs are pretty much equivalent to warfarin. And DOACs are preferred in patients with atrial fibrillation given better safety profile. And regarding the timing, which this is probably one of the commonest questions I encounter in my practice, is to when it is right time to start these patients. So let's say we said this is cardioembolic stroke or this is cardioembolic TIA. When can we start these patients on oral anticoagulation? So if it is a TIA and on the imaging there is no infarct, so basically this patient can straight away go on to the therapeutic anticoagulation on day 1. The problem is when somebody has a stroke and you see infarct on the scan. In that, there's a lot of debate as to what is the right time. Some of the factors which I mentioned here is what I look for is what is the size of the stroke, is there any hemorrhagic transformation already there on imaging, how the blood pressure control is there any other hemorrhagic tendency like how the platelet count is and how the baseline INR is. So based on that, you can determine whether to hold for a few days or can we start this patient on or anticoagulation. In general, this is one of the proposed algorithm, which is if the stroke is not large, there is no hemorrhagic transformation, then these patients basically could be started on anticoagulation within the first couple of weeks. There's actually a lot of emerging literature where patients who with the mild to moderate stroke could be started as early as within the first 5 days, and there has been no evidence to show that safety is an issue. So it is better to start early than later, but of course we should ensure that the patient is stable, the blood pressure is controlled, especially if the size of the stroke is or infarct is big. And which one should we really prefer? And I think all of us are aware that warfarin was the first agent which showed significant stroke reduction, and DOACs has been shown to be equally effective and in some cases rather safer than warfarin. And many of us are familiar with the 4 agents which are being used, there's really no big evidence to suggest one is better than another. Of course, it will depend on what the underlying comorbidities are, and there is some safety signal in some, while others may not be preferred, especially if somebody has a GI hemorrhage. One agent might be preferred over another one, and again, we can discuss it during a Q&A session if somebody is interested. About the PFO, it's only younger patient, which we should be too much worried about, because older patient, we don't have much robust data. These patients need to have embolic stroke with all other etiologies, or at least common etiologies, excluded, and no better anticoagulation indication. So therefore, not every PFO needs closure. That's the key message here. Only the patients who fulfill the criteria which I've mentioned here needs. So those are younger patient, embolic stroke, and no better etiology. While large artery athero, to make things very simple, we have arch, extracranial, and intracranial. For the arch, there's no evidence of different treatment approaches, which is better, whether give single, dual, or give warfarin. At this point, either strategy with either single or dual antiplatelet is okay. In case of extracranial arterial disease, if it is a carotid disease, it needs consideration for revascularization. And in the vertebral artery disease, its medical therapy is preferred initially, and while the angioplasty and stenting is reserved only if the best medical therapy fails. It's very important that the carotid intervention has to be done early, preferably within the first 2 weeks. Therefore, we should expedite the workup. And in case of intracranial disease, one important message here is that instead of giving 3 weeks of antiplatelet, which has become commonplace in stroke world, we typically give 3 months of antiplatelet therapy, again suggesting there is a difference based on the intracranial disease, atherosclerotic disease. And as far as the small vessel disease is concerned, it's important that these lacunar strokes, they look small, but they carry high risk of early deterioration. Therefore, some of the patients requires admission. There are 2 basic patterns. One is called the branch occlusive disease, another is called the lipohyalinotic, depending upon where the occlusion is. And they both behave in a quite similar way, while the branch occlusive disease has a much higher risk of early deterioration. And what we know is early dual therapy helps reduce deterioration. Long-term dual is detrimental, so patients should not be maintained on long-term dual antiplatelet therapy in these patients, and we should control the blood pressure aggressively. And the other important group is the dissection. If it is extracranial, either antiplatelet or anticoagulation is fine, preferably dual if there is no obvious contraindication, while the intracranial dissection, things are more difficult at this point to really recommend which therapy is better than another. And again, it requires very, very individualized approach compared to the extracranial dissections. And so the summary here is that each stroke etiology has distinctive management algorithm or strategy. And it also determines what should be our initial choice and the subsequent choice. And the choice between anticoagulation versus antiplatelet also depends on what is causing the stroke. And so after discussing all this, is too much information? Can we have a practical one-pager here? So this is the take home. This is a very simplified approach. Again, I would say it's a personal approach where what you do is you ask yourself, this is TIA and stroke. Is there any obvious cardioembolic source? If answer is yes, then we consider anticoagulation. If the answer is no, then we load these patients with aspirin and Plavix. So always dual, as shown in the two large trials, that the early dual antiplatelet therapy is non-cardioembolic TIA and minor stroke helps. Now, if it is a major stroke or a big stroke, we need to be cautious and add high-dose statins. And all the patients should undergo arch to vertex imaging, whether you're using a CTA or you're using MR angiogram, it's up to you. A Doppler itself gives only information about the carotid. They give no information about the intracranial status. And as we know that knowing intracranial status is important because it might extend the duration of antiplatelet bar to 3 months instead of 3 weeks. And it also gives you the idea if there's any intracranial dissection, which can contraindicate anticoagulant therapy. And so in conclusion, etiology determines the presentation and natural history of TI in stroke. This is the most, etiology can be easily determined by using a structured approach, which could be individualized to the patient. And each TI in stroke etiology has distinctive treatment approaches, which could reduce the stroke outcome, especially the recurrence rate. And the early distinction of cardioembolism versus non-cardioembolic stroke, while in non-cardioembolic, knowing a vascular status is very crucial. And early and aggressive prevention strategy can be very effective in reducing the stroke recurrence rate. And so we are celebrating our first anniversary of the EVT program. And this was our first case. And you can see here a big clot was removed and patient is doing fantastic. This is our team. And everybody has worked tremendously hard. And Dr. Priola, I couldn't get a better picture, so I had to crop in from Facebook. Thank you so much for attending. Hello, everyone, and thank you for sticking around. And we'll be discussing the second part of the present webinar here, which is discussing a few cases. And the idea is to apply this concept of etiological diagnosis in the individual patient management. And what I'll be going through is showing you a couple of cases, and we'll walk together with some questions as to how we should approach these patients. And again, these are the patients which were seen here in our clinic or in hospital settings. So those are real cases, and we'll discuss the management approach here. So before we go on to discussing the approach to individual patient, just to reiterate, I'm not sure if all of us are familiar with this risk stratification tool, which time and again I kind of show and discuss. The idea here is that while working in this part of the Canada, we are not only physicians, but also we are matchmakers, where we are ensuring that the patient is getting care in the right healthcare setting, which might include transferring these patients to a different hospital or sending these patients to particular outpatient setting. So it's very crucial to risk stratify these patients so that a timely referral or a timely transfer could be initiated in these individuals. And what I'm showing you here is when you get a patient who had a transient symptoms or had a minor symptoms, we basically plot the symptoms and the time and see where does the patient stand and what is the urgency of the workup. And that will dictate where these patients should be worked up. And again, the setting could vary. You might be working in the emergency setting where you have easy access to imaging, or you might be working in a hospital which do not have immediate access to imaging, and these patients might need a transfer back and forth, again, in our setting. And the third is that you might be working in an outpatient setting where you don't have a quick access to the imaging. So again, sending it to the right clinic in a timely fashion or transferring to the right hospital is very, very crucial. So the way we divide it is very easy. We look at what kind of symptom patient had and how far the patient is from the episode, and those two together then determines what is the risk category of this patient. And again, I'll be showing in this this patient as to how we can apply this this model. The patient, again, the timelines are suggestions or recommendations. Again, we might have to tweak a bit based on our local setup. But this might include that you might have to refer this patient to a nearby emergency department, which is imaging capable, or this might entail sending the patient to stroke prevention clinic if your clinic is working 7 days a week or does not have wait time. So again, it'll vary from region to region, but this is a general guidelines and based on best practice recommendation. So here's the first case. So we have a 55-year-old male who had about 10 minutes episode of right hand weakness and numbness with right facial droop and dysarthria about 3 days ago. The past medical history was relevant with the history of coronary artery disease, hypertension, dyslipidemia, smoking, and Crohn's disease. On examination, his cardiac and vascular examination was completely normal, and there were no focal neurological deficits. So the first question is, and again, this is based on the assumption that you're lucky enough to be working in the right setting and you have easy access to all the stroke workup. And again, you would be choosing what you think is the best answer. So what would be your next test? So let's say you are working in the emergency department and you have access to imaging. Which test would you choose? And there might be more than one right answer here, but I would suggest choosing the best one. Again, in most circumstances, that'll depend on the local access. But I think across Canada, there is some consensus. So let's see if we have a consensus here. There has been a lot of discussions and debate as to whether we should be CT based or MRI based. And again, the scenario might differ between what's happening in North America compared to what's happening in Europe, because there are a lot of centers in Europe which have very easy access to the MR system. Great. So I'm looking at the poll results, and this is fantastic. I think I don't have to really emphasize how important it is to do the brain and the vascular imaging. And we got 81% ordering a CT head with the arch vertex CTA, which is fantastic. And again, just to reiterate, a carotid Doppler is acceptable alternative, but as I will show, may not be the most appropriate test. Again, just to reiterate, in this particular patient, we had symptoms which are motor and speech. So this patient had motor and speech symptoms, so that along the symptom spectrum, this is the highest category, and this patient is coming at 3 days, which is falling between 48 hours to 2 weeks. That means patients should be assessed within 48 hours. And again, this might mean that if you have, if it is Monday, this could mean that you're sending this patient to, or referring this patient to the stroke prevention clinic. But if this is Friday evening, then that could mean that you are sending this patient to the nearby ED. So in this particular patient, I agree, I would have ordered a CT head with the arch vertex CTA. Again, showing that when we understand the concept of TIA, there is a very important aspect between T and A, which is I, that is ischemia. And we do know that a lot of patients with the transient symptoms do not have underlying ischemic etiology or ischemic mechanism. So it's very crucial to distinguish these two. And the simplest test is to do a brain imaging. And what it shows is one on the left panel, you can see in the left central sulcus, there's a blood. And this blood is typically seen in patients with either cerebral amyloid angiopathy or similar conditions where they have a sulcal hemorrhage. And these patients are at quite high risk of further intracranial hemorrhages. So therefore, you do not want to start these patients on antiplatelet or anticoagulant therapy. While you want to see these kind of patients where they have a small areas of infarct, or the imaging could be completely normal. So it's again important to distinguish that every transient symptom is not ischemic in nature, and this concept is also crucial. Although this is not a very common scenario, it's important to be familiar with this concept, and this is called TFNEs, which is transient focal neurological episodes. And the idea here is, instead of the ischemia, the underlying mechanism is a small area of hemorrhage, which is producing a transient symptom. And this is contrary to the previous concept, where we thought that if it is a hemorrhage, it has to produce a persistent symptoms, but not so. So therefore, the notion that the presence of hemorrhage will produce persistent symptoms, therefore a transient nature of the symptoms suggests underlying ischemia, is not true. And so it's important that doing a simple brain imaging will be able to help you distinguish the two. And here you can see there's a lot of studies done, and what it showed is that in the first 2 or 3 months after this TFNEs, the risk of intracerebral hemorrhage is up to 25%. So that means they are not at risk of ischemic stroke, but they are at risk of having hemorrhagic stroke. And again, you don't want to anticoagulate these patients or start them on antithrombotics. While on the ischemia spectrum, it's very interesting. This was a study done at Calgary. This was a prospective study. What it was, essentially the idea was to see if somebody had a CT or the CTA and it was abnormal, what is their subsequent risk of having ischemic stroke. At the same time, these patients also underwent diffusion-weighted MR, and again, the theme was the same. What is the likelihood? Is imaging able to risk stratify these patients better? And again, what you can see here, there's a red line, which is the upper line with the 95% confidence interval, and you can see clearly the risk is much, much higher. And if you see, the risk is early risk. So the separation between the two curves happens very early in the first 24 hours. So an abnormal CT and the CTA predicts a high likelihood of having early recurrence. So therefore, doing a brain and vascular imaging is very, very crucial, and is one of the most important risk predictor for subsequent strokes. And it's very interesting, in the same study, the negative predictive value of a normal imaging was over 95%. So that means if you have a completely normal CT and the CTA, the risk of subsequent stroke in this individual is lower. I will not say it is very low, but it is lower than someone who had a positive CT-CTA. The same thing works with the diffusion, although it is not as robust, but definitely it is a useful predictor. And again, there are a lot of people who believe that intracranial stenosis is often not looked at, and people do just the Dopplers and forget about the intracranial stenosis. Very crucial that these patients are at high risk of early and late recurrences of the stroke, which is quite high. So in most setting, it will be CT head with arch to vertex CTA. And this patient had completely normal brain and vascular imaging. And would you consider MRI brain in this person? And I'll be going a bit faster because I see that Sue is already giving me a warning that we might go past our time. So we'll quickly go through the poll. Again, I'll show some literature which says that MRI after TIA is positive in substantial number of patients. It depends on duration of symptoms. But even in the patient presenting in the who had only less than an hour episode, a lot of patients do have positive MRI, and so it's important that to understand this concept. Again, it might depend on the local availability of different imaging modality which are accessible. So we'll wait for the poll results. Again, just to further demonstrate the same concept that even in TIA as well as minor stroke along different stroke severity, the rate of diffusion positive lesion increases, and we do know that the number of diffusion lesion predicts, as shown on the right side in the TIA registry, that more the number of infarcts, the higher the risk of early recurrence. So it's again helps to risk stratify these patients. So therefore, I would have done the MRI, and we did. And here you can see that there are a couple of areas of diffusion restriction, which again suggests this patient is at much higher risk of subsequent ischemic event. The next question is, what test would you do next, which will entail that now you know that the brain and the vascular imaging is normal, while the MR showed a couple of diffusion hits, which looks embolic in nature, and what would be your preferred test? And there are a lot of options here. And again, for the interest of the time, I would just show best practice recommendation, which says we have to do EKG, 12-lead EKG in everyone. We have to do at least 24 hours Holter, or preferably longer, where you think that the underlying mechanism could be embolic, and these patients might need anticoagulation on board. While the echocardiogram could be considered in the select cases where the mechanism has not been identified. Therefore, my preferred approach would be to do a transthoracic echocardiogram with bubble study with short-term Holter. And let's see what the poll result says, and then we'll move on to the next concept. Unfortunately, I lost access to my second computer, but anyways, I'll keep going. So the cardiac workup showed a normal valves with normal ejection fraction, and the left atrium was enlarged, while the 72-hour Holter showed no AFib, and there were quite a few supraventricular ectopics. And next question would be, which test would you do next? So in this patient, we have a 48-hour Holter, which is negative. We have echocardiogram, which shows some suggestion of left atrial enlargement, and we still don't have the mechanism. Of note, this patient was started on dual antiplatelet therapy for 3 weeks, followed by antiplatelet monotherapy, and also started on high-dose statins. Again, for the interest of the time, we'll move a bit quicker. For patients who are being investigated and where you don't know the etiology after the initial workup, you should do at least 2 weeks of Holter, especially in patients who are over the age of 55, where you think they would benefit from monitoring. They would benefit from oral anticoagulation. And again, we know from several studies in the past, longer you monitor, more the likelihood of picking the atrial fibrillation, and the answer would be 4 weeks of Holter. And so this patient had atrial flutter on the 2nd week and fibrillation on the 4th week, and this patient was started on apixaban, 5 milligrams BID. And again, just to show that every patient should be started on oral anticoagulation if they fulfill the criteria, which means having atrial fibrillation, which is non-valvular in etiology, and warfarin in patients who have valvular etiology, while the NOACs are preferred in non-valvular conditions. And just to show that most of the NOACs have equivalent efficacy, and in some cases much safer. And it just shows that we have 4 agents, and important is rivaroxaban has to be taken with meals, and the dose adjustment might be needed based on the renal function. And so in this patient, just to demonstrate, if we go from the left to right, this patient had speech motor symptom, had left hemispheric localization, and outcome was the stroke, which is minor stroke. Mechanism was embolic, and this is cardiogenic, and underlying risk factors AFib. So this is a kind of a complete diagnosis for this patient. And the case number 2, again, I might have to rush through it before we go to Q&A. And again, we don't have a time to go through all the questions. Again, just to show 82-year-old lady who presented with acute motor and speech symptom. And I would have done CT head, which are to vertex. I think we have a consensus. You can see there's a lot of multiple areas of stenosis. This is clearly intracranial atherosclerotic disease. And what we really don't need any further testing because we have a very clear etiology. And in this case, just to further show that there are a lot of other areas of atherosclerotic changes, suggesting this is a severe intracranial atherosclerotic disease. Again, shows why it is important to have intracranial imaging, which these findings will never be picked up on the carotid Dopplers. So in this patient, we have a speech motor, left hemispheric localized major stroke. Mechanism is embolic plus hyperperfusion, intracranial atherosclerotic disease, which is large artery atherosclerosis, and risk factor, she has multiple. So that's basically it. And again, sorry for rushing through the last part. It was, I had very little time, and I see the smile on Sue's face. So I'm ready for the questions and answer. Maybe 1 or 2, because we are probably already past 9.
Yeah, we have a number of questions. I'll try and get through them. So we're going to go past 9 o'clock, obviously. And for those that can stay on for the questions, that's great. And then this webinar will be archived. So if you've missed the ending and you want to go back and listen to the Q&A afterwards, you'll be able to do that. So thanks for that presentation, Dr. Singh. And I'll start with the first question. Is the recurrent stroke risk discussed in slide 9 natural history risk or risk with etiology-directed secondary prevention?
Yeah, so the overall prognosis in the stroke or TIA population is determined largely by the etiology. And once somebody has a major stroke, of course, then we start talking about the size of the stroke. But that prognosis is mainly for the disability and the functional recovery, as well as mortality. So there are 2 aspects to the TI and stroke prognosis. One is individuals who do not have disabling deficit, and another is for individuals who have larger stroke with disabling deficit. So the questions are slightly different, because in the first group, we are more worried about the recurrence rate. In the second group, we are worried about both the recurrences as well as the functional outcome, and also that entails the mortality outcome as well. So the risk is slightly different with a slightly different theme, and both are determined by the underlying etiology, because we do know that the bigger strokes tends to happen with the larger clots, and the larger clots typically tends to come from the heart or the bigger arteries. So again, they are kind of collinear in that regard, that one predicts another. So there's no easy answer to that. I would say etiology is still the preferred risk stratification tool. Either you are seeing the lesser end of the spectrum in terms of disability, or the higher end of the spectrum.
Very good, thank you. Next question. Do hypercoagulable state associated strokes end up being in the other etiology class? What about VIPIT or venous thrombosis for that matter?
Right. So again, very important question. That's correct, because what we do is basically take 3 major etiologies and give them 3 different categories. So we have cardioembolic, large artery athero, and small vessel disease or small vessel occlusion. And then we have other categories, which is other defined etiologies. So the hypercoagulable state related to different condition, which could be either VIPIT or could be antiphospholipid antibody syndrome, could be inherited thrombophilia. So that would go under other defined etiologies or the other determined cause. The question about CVST, now this classification system is geared towards arterial stroke. So it truly doesn't apply for the venous strokes or the hemorrhagic strokes. And they are mechanistically different conditions. So, and we have different set of classification for them as well. If there's interest, we can always discuss. But there, the predominant concept is very similar to what we use for DVT PE, that we try to define the underlying thrombophiliac state. And so this classification is for arterial strokes only.
Thank you. The next question, can you please comment on the role of the D-dimer and BNP post-stroke? Thank you.
That's, I think, a great question, especially in the setting of cardiogenic embolism. There's a lot of interest that if somebody has elevated troponins or BNP, when they come to emerge or during initial assessment, the risk of underlying cardiogenic mechanism or cardiogenic etiology is much higher. And the second part to this is that even if we are not able to establish the etiology like underlying AFib, these patients might go into a second category called atrial cardiopathy, where the BNP is elevated. And there is now a trial going on which is assessing the role of anticoagulation in non-AFib atrial cardiopathy. So there are several studies, observational studies, which showed it has prognostic role. Two, it does predict underlying etiologies, and it can be used in select cases based on the local experience. Again, I use it. Troponins are done on everyone, and I use that to my benefit to see if there is an underlying, there could be potential underlying cardiogenic etiology. And yes, BNP, I do order, especially in the cryptogenic stroke, where I'm kind of preparing that in case the trial is positive, I can call these patients back and start them on anticoagulation. So yes, definitely, if you have a cryptogenic patient, then definitely BNP would be useful to say if they are having atrial cardiopathy.
Great, thank you. Not sure about this next question. I'll read it out. Is CTA equivalent to MRI anvil to determine vascular etiology?
Right. Well, they kind of give you slightly different information. If you ask me in the perfect world, I would be doing both because they're kind of complementary in a lot of ways. Again, it'll depend on the protocols which are being used. So a lot of this drills down to what are the different vascular protocols, because most of the MRs are being time of flight MR, which doesn't give you any idea about the plaque, doesn't give you any idea about the wall of the vessels, where the etiology might lie. So I would say there are a lot of, unless you're using the right sequence of the MR angiogram, in most cases, the CTA and the MR becomes more of a complementary. And if you have access to both, and if you have the right protocol in place where the MR can do the right brain sequences as well as the right vessel sequence or vascular sequence, then absolutely they are equally good. Or in some cases, as far as the brain is concerned, the MRI outperforms the CT by demonstrating those small little diffusion hits. So definitely from the brain perspective, MR is much better. While from the vascular perspective, again, it depends on what kind of imaging sequence you're using in the MR, which might be same or sometimes even better.
Great, thank you. Next question. If someone has a stuttering TIA where symptoms completely resolved in between episodes and starts having another episode, does the time to TPA or EVT restart from the second episode, or is timing from the first?
Right. So that's, again, very interesting and the tricky question. And again, there's no answer to this, right answer to this. I would say when I'm seeing the patient, and if in between patient had completely resolved, and most cases we say completely based on historical data, while the patient says, "Oh, I recovered," and while if you do these see these patients in the emerge who are stuttering, you would notice that all the patient says that he's better, but you could still see the neglect, or you can still find the hemianopia. So I'm not sure that whether based on the true historical data you can reset the clock, but if you have the benefit of examination, then absolutely you can reset the clock if you're sure that patient was in between those episodes normal. But to me, it depends on how the brain and the vessel looks, because if this was the same clot and this is the same brain, which looks well preserved, despite patient having stuttering symptoms, I do know this is the same stroke and it's not a different stroke happening, because the whole idea is to ensure that we are thrombolizing the right stroke, right? And so the time if you are seeing a clot which is M1 and patient having stuttering course, it is basically the same stroke. So there's no need to really reset the clock. Now, of course, for medical legal purposes, you want to reset the clock, then that is if you can establish based on the good historical data, or based on your assessment that patient was normal in between the episode, you technically could reset the clock.
Very good, thanks. We have 3 more quick questions. Is 48-hour Holter enough?
Not really. As I showed you in the example above, it's a sequential approach. So what I do personally is I usually order 24 or 48-hour Holter in the beginning. Sometimes by default 72 gets ordered, but my personal preference to do a short-term Holter monitor and do an echocardiogram, which especially if I don't have an obvious etiology, that means the vessels look clean. And I'm strongly suspecting this is going to be cardioembolic because there is no lacunar infarct. It was embolic stroke. So you have embolic stroke, clean arteries. Then I use the echo and the initial Holter to risk stratify. And if I don't get the answer and I get the signal that these are patients at high risk, I keep going. So after the first 24 to 48 hours, we go for 4 weeks. And you can either do 2 weeks and 2 weeks, but that kind of delays the entire process, but it might be right under your setup. So if that is the way it works for you, you can certainly do that. But I order either another 2 weeks if I see that there are a lot of supraventricular ectopics, and 2 weeks highly likely will be positive, or I order 4 weeks where I see low prevalence of supraventricular ectopics. And so it is either 2 or 4 weeks Holter. Again, based on the best practice guidelines, the minimum is 2 weeks. But I would say in most cases, I would just go for 4 weeks. And if that is negative, I would just go for the implantable loop recorder. Again, at the same time, we have to be mindful that we need to rule out PFO. We need to rule out any other defined etiology, which may not get captured by this standard cardiac investigation. So sometimes it is individualizing rather than having a common recipe for all. So it's basically a precision medicine where you kind of individualize approaches in each patient. But generally speaking, you do a short term followed by a long term Holter and then implantable loop recorder.
Great, thank you. The next question is how long DAPT?
So the DAPT or a dual antiplatelet therapy, if you look at the 2 trials, which was Point and Chance trial, and also a lot of observational data which use dual antiplatelet therapy, overall the conclusion is that we should use a short-term aggressive dual antiplatelet therapy, which means giving 2 of them with initial loading dose for the first 3 or 4 weeks. Now, based on the Chance and Point, there is a slight difference. They use the approaches, but based on the best efficacy and safety combined together. So net clinical benefit kind of maxes out between 3 and 4 weeks. So when I'm prescribing, I typically prescribe for 3 weeks, and in some cases 4 weeks, and 3 months only in select cases where there is intracranial atherosclerotic disease, or longer as they are waiting for the carotid endarterectomy or carotid procedure to be done. In most cases, if you don't have a robust indication for continuing beyond 3 weeks, I usually stop at 3 weeks, and then we continue the etiological workup.
Great, fine. This last question then, in the final case, what would be the optimal treatment strategy?
Right. So as I was alluding to that in this patient, we have indication for prolonged dual antiplatelet therapy. So this patient had a severe intracranial atherosclerotic disease. So that means this will be classified under large artery atherosclerosis. And in the large artery atherosclerosis, it is intracranial type. And these patients are at much higher risk of both early and delayed recurrences. And there were a couple of trials done. One was medical therapy, which is VASID trial, and the second was the Sampras trial, which used the stenting approach. And overall, the conclusion was, or takeaway was that if the patient is presenting in the first month of their initial symptoms, they should be put on dual antiplatelet therapy for at least 90 days with aggressive vascular risk reduction, which entails, control of blood pressure, high dose statins, and managing the lifestyle risk factors. So it is 3 months. So I would treat this patient with 3 months of dual antiplatelet therapy and then reassess if we need to go beyond that or not.
Great, thank you. So we've gone 15 minutes over, but it's been a really excellent presentation, really good questions. So thanks for staying on to share those questions and listen for answers. Dr. Singh, thanks a lot for sharing your knowledge today and your expertise in this area of stroke and TIA etiology. As one of our registrants has said, thank you for excellent clarity in evaluating these patients. It's much appreciated. So just remind people to take a minute to fill out the survey. The link is on the screen that you can click onto it. We'll be archiving this webinar for future viewing if you want to share it with colleagues. And if you have any questions or comments, feel free to email me at any time. So thanks for attending today, everybody, and please stay well.